Rebecca, can I hand to you?
Yeah, of course. Hi, thank you. Good morning, everybody. Appreciate I've got the slot before the break, and I've only got 6 minutes, but hopefully I can run over a little bit if that's okay, just to cover what I want to cover. So, nice to meet everybody on the call. I'm Rebecca Wilson. I am the founder of DigiSafe Compliance, and my background is I'm a registered clinician, but I am a senior clinical safety officer. So, I've been working in the world of digital health for over a decade now, born out of the NHS. And really, our organisation and company specialises in clinical safety. So we've heard a lot this morning about regulation, compliance, and the standards. So I wanted to delve into actually what the standards are for those on the call that are not aware, and actually what that means in reality. A little bit more about us. So our DigiSafe compliance of 16 CSOs at the moment, various clinical and social care backgrounds. We also cover the whole of DTAC. So you may have heard of DTAC, which stands for Digital Technology Assessment Criteria. So we have DPOs, we have cyber and technical specialists, and we also cover medical device regulation. And the reason that we was born really was because we saw the gap really in terms of compliance and what people are doing, not just now with AVT, but historically. And just to mention, there's a lot at the minute. Compliance is raising its head because of AVT, I would say, but the standards and all of this has been mandated since 2012. So actually, this is nothing new. So I want to put that straight out there because I know there's a lot of conversation around, there's a lot of questions and challenges around AVT and the clinical safety, but actually, the DCB 0129 and the DCB 0160 standard are both mandated standards and frameworks under the Health and Social Care Act 2012. So they've been here for a while. They're not yet mandated in Wales, Scotland and Ireland, but they do use them as best practice, and there will be some form of Welsh standard mandated soon. I've seen that we've got many CSOs on the call as well, and I think, over the past 10 years, I've seen a lot of clinical safety officers train, we've got a good community together, and we're really trying to raise the bar of actually what the standards are and what they mean. So the DCB 0129 standard is very much aimed at what we call the manufacturers of digital health IT, digital health, medtech, the different various terminology that you will hear within your digital health and care sort of realms and within your environments. And basically that framework, very much similar to the 160, stipulates that you must have a clinical safety officer, which is a registered clinician with risk management experience. Basically, the framework was developed to ensure that there was no increased harm to the patients from the development and the deployment of the products that was going to be used. So this isn't just for AVT, it's for all digital health and care products that basically touch a patient. That includes clinical decisions, diagnostics, demographics, etc., and so on. Doesn't currently cover well-being though, just to mention. So I feel like the standards were very much written for the hospital trusts and for the manufacturers at the time. And as we've expanded over time, innovation, integration, interoperability, it's become a whole spider web really of confusion and challenges that we are seeing across the board when it comes to compliance and digital health deployments. So the standard for 129 obviously covers manufacturers of all that digital health and tech and AVT. And the DCB 0160 covers the deployers, basically, of that digital health technology. So when we speak about the deployers, that is anybody within the health and care realm sectors. So social care, GP practices and primary care, pharmacies and PCNs, hospital trusts. And what we've heard on this call and what we are seeing is there is a real challenge and lack of awareness and understanding of actually where the standards sit and who should be responsible, what and where. So what we aim to do and what we are doing is we train CSOs, so registered clinicians, we raise awareness and we help with the consultancy and the compliance. But what we're really about is not ticking the box and doing the documentation, which we should and must do, but it's about embedding the process with the people. And I cannot emphasize it enough. It's not about having a fancy hazard log and a safety case. It's actually about the whole organisation having clinical governance in place from the start, which actually you would see that many organisations have. So, in GP practices, there'll be clinical leads. In hospital trust, there may be clinical safety teams. Vicky Fain has spoke on the call at Leeds Teaching as a fantastic clinical governance structure and clinical safety team in place. So I think in response to one comment somebody said that CSOs don't know what they're doing. I would argue that actually we do, and AVT is no different to what we do in any digital health and care deployment. What we do as CSOs is we analyse the product and the documentation set that we are provided from the supplier, and we evaluate and we estimate clinical risk. And actually, my advice to suppliers in all digital health and AVT is to make it easily digestible in plain English to the deploying sites, because we do have, that challenge in terms of understanding, not with the CSOs that are there, but with the whole teams, I would say, within terms of digital projects. And the thing is, for me, in terms of clinical safety and embedding the process with the people, it's not just the governance, it's bringing everybody on the journey. The whole project team should have a clear understanding of what compliance means. We should always be referencing back to the intended use and the scope, because within the clinical safety case and within medical device registration with the MHRA, everything comes back to the intended use and scope of that product. So as long as we're aligned to the scope and we fully understand that and we're aware, and we can complete our analysis and evaluation as any digital health and care technology, then that sets us up for success, I would say. And that will define a clear checklist and requirements of actually what we need to do in deployment. And again, it's the standard structure of what do we need to do. It comes down to the health IT testing, it comes down to the business processes, and it comes down to the training. And actually, what are the manufacturers like Tortoise, Heidi, etc., telling us in their DCB 129 safety case and hazard log? What recommendations are they presenting us with, and what transferred hazards and risks do we need to consider? And from a deployment point of view, it is having that sort of confidence in reviewing that and that validation from the CSOs and the clinical teams and non-clinical that should be part of hazard workshops within the process, to ensure that the assurance is there, the validation, and therefore gives the confidence in the deployment of the product, AVT and others. Now, yes, AVT is new shiny object. Everybody wants it. There's uncertainty, etc. And, we can't get away from that. But it's similar to what we had with shared care records, when there was all that integration of shared care records and connecting data together. So I think, yes, it's new where we are now, but it's no different to what we've been doing. And what we've been doing is we support innovators and manufacturers to ensure they're not just DCB 129 compliant, they have the whole of DTAC. So they have, as I think Leon mentioned as well, there was the CCIO letter from NHS England that stipulated set criteria. So we ensure that, that all the suppliers have their Cyber Essentials Plus, that they have their DSPT, they are registered with the ICO, they are a medical device class 1, but have on their plan they're going to register as a class 2 as well. So we work with both innovators and suppliers to ensure they have the compliance in place, a nice DTAC file, but that they don't just throw it over the fence. They actually work in partnership with the organisation so they understand what that means. And actually, if they can draft a nice 160 as well as a starting point, can help with those challenges when it comes to capacity issues at the other end. From a 160 point of view, we're supporting NHS trusts and predominantly ICBs at the moment and primary care, with working with Humber and North Yorkshire ICB and West Yorkshire ICB in terms of reviewing the suppliers that the GP practices are wanting to use. So we are completing what we're calling a core generic 160 for that product and sharing it across the board with a clear checklist of, we assure and validate the product, and this is what you need to do. Because in reality, the users just want to use it. They want to see the benefits and the outcomes. But what they want to be is assured by the product that it's been through clear governance and they have a clear checklist of actions to undertake. So the standards have been mandated since 2012. They're for everything. There's just more noise because of the letter and everything else that's going on at the moment. But I think the thing is, it's having that clear governance, the communication, having a platform which is really interesting, where we can be transparent and share what we are learning and what we are doing with others. And I think it is really key. And also having that ongoing lessons learned and feedback loop as well. So especially when products go live, it's not just go live and that's the end of the story. It's like we've seen from the further presentations before, is what's the the ongoing mechanism in terms of any lessons learned, instant reporting and feedback for change. And products are going to change and we're moving faster than I think we can keep up. But as long as we keep that clear governance in sight and we work alongside the other teams and we're bringing everybody on the journey, I think you can set yourself up for success. So if you want any advice in terms of clinical safety, compliance, DTAC, medical device, anything that I'm seeing in this crazy world, then I will drop all my details within the chat. But I just think, yeah, we're obviously addressing all these compliance issues and we're speaking about them now, which is fantastic. It's keeping up that noise collectively, not just on AVT, but on everything else that's going on as well. Thank you.
Fantastic. Thanks so much, Rebecca. And you brought real clarity to what you described at the start as that spider web of confusion. And it can feel daunting, but actually it was really helpful to see that set out. And you made a really good point about working with the supplier to overcome some of those barriers. And Nick at the start talked about how Great Ormond Street had worked with Tortoise to navigate some of the IG piece. I think the reminder also about being very clear about the intended use and scope of a product is absolutely key here, isn't it? Before we break, are there any questions that anyone has for Rebecca or for Neil? In which case, a huge thank you for your time. Please do put your contact details, if not already, in the chat, because I know there will be questions and people will want to follow up.